This is Larry Brockman with the Office of Air Quality Planning and Standards. We wanted to again thank Dr. Arden Pope for joining us and all of you for joining us on this webinar today. I apologize for the little late start here. I'm going to go through some quick slides just to provide a little bit of background and context before Dr. Pope gets started on his presentation on PM 2.5 and health effects. I'm going to go ahead and moving to the second slide, and really just briefly, why is wood smoke a concern? Wood smoke is made primarily up of fine particles, and we're going to hear a lot from Dr. Pope on fine particles and health effects associated with fine particles. Of course, wood smoke is made up of a lot of other toxic chemicals, some cancer-causing, carbon monoxide, as many folks realize, and then there's the polycyclic aromatic hydrocarbons, benzene, formaldehyde, toluene, lots of chemicals in wood smoke to be concerned with. From an environmental standpoint, certainly visibility is an issue in some areas because of wood smoke, wood combustion. Again, looking at kind of the magnitude of fine particles in the U.S. From residential wood combustion, over 350,000 tons of fine particles comes from residential wood combustion, and that's more than all the refineries, pulp and paper mills, cement manufacturers combined. And that's really, we're talking fireplaces, outdoor wood boilers, wood stoves, mostly coming from wood stoves, but certainly all of those contribute in various magnitudes, different parts of the country. Looking at hazardous air pollutants and what's coming from wood smoke, we've got nationally 62% of the 7 polycyclic aromatic hydrocarbons come from residential wood combustion. And then nearly 24% of the area source cancer risk is derived from wood combustion. And then you can see that wood combustion accounts for about 15% of the overall respiratory risk. So some real reasons why we are concerned with wood smoke from the fine particle standpoint and from the toxic standpoint. The other component is low stacks compared to a lot of power plants, for instance, or other sources. Low stacks and wood combustion is usually done during the residential during the winter times where you have poor dispersion in neighborhoods and in and around homes where that can actually get back into homes, and so you have indoor air problems also. Here's a photo of an outdoor wood boiler, a hydronic heater. Particularly these are prevalent in the Northeast, Midwest, and becoming more and more popular. Again, you can see lots of smoke, low stack, poor dispersion, and potential for high exposure to this, obviously to the families of the home, but also anyone in the neighborhood. You can see in the next slide, one of these units can really blanket an entire area. This is just one unit from one home. Again, poor dispersion, and just as an example of what we can get from residential wood combustion, can be widespread. Looking at the non-attainment PM 2.5 non-attainment areas and designations from 2005, 2009. Now, wood is burned across the country. Certainly, in every state we get complaints and issues, calls from people. But certainly out west, one of the primary drivers of the non-attainment status is wood smoke. And it's not just small communities, but also larger areas like Tacoma, Seattle, Sacramento, and then even in the southeast, you have 15% of the overall PM can be attributed to residential wood combustion, and more so in the northeast. Finally, and Dr. Pope's going to kind of get into this in greater detail in just a second. We looked at if you were able to pretty much just flip the switch and change out all the wood stoves in the United States, which is about 7.5 million old ones, the health benefits derived from reducing the fine particles associated with those wood stoves is quite impressive from the standpoint of overall health benefits, anywhere from $35 to $86 billion. So that's all. That's really the only slides we have on this. I just wanted to bring this point out that this is a real significant, potential significant benefits from addressing wood smoke, and just wanted to kind of set it up for Dr. Pope to take the lead from here. EPA has our BurnWise website where you can get more information about our programs. So briefly, Dr. Pope is currently a Mary Lou Fulton Professor of Economics and Associate Dean of the College of Family, Home, and Social Sciences at Brigham Young University. He's got a PhD from Iowa State and was a fellow of the Harvard School of Public Health. He's done lots of research dealing with various natural resource and environmental issues. His cross-disciplinary research in environmental economics and air pollution epidemiology has resulted in really some seminal studies, and you're going to hear a lot about that now that I've turned this over to Dr. Pope. And thank you again. And we'll be receiving questions and try to get some questions addressed throughout this presentation. So turn it over to Dr. Pope.
Great. Well, thank you for the introduction, and I hope you all can hear me well and see the screen well. I was asked to speak about the health effects of particulate matter air pollution and sort of trying to tie in the wood smoke issue as it relates to that. I mean, the bottom line with regards to starting to discuss this issue, it's very important we understand that over the last several decades we've learned that what we breathe substantially impacts our health. And of course, ideally we'd like to breathe pure air, but in fact the air we breathe is contaminated with various gaseous pollutants as well as particulate matter and other air toxics. Now, the subject of this webinar is really to look at fine particles, that is, particles that are less than 2.5 micrometers in aerodynamic diameter. This basically includes wood smoke, and we're going to focus on fine particulate air pollution, recognizing that wood smoke is one of the very important contributors of PM 2.5 air pollution. So I'm basically, you can see a sort of a figure that looks at the size distribution of particles. You can see it's sort of trimodal. There's these ultrafine particles. They tend to coagulate and form the aggregates that we really talk about, or the accumulation mode we talk about in terms of fine particles. There's a lot of coarse particles out there in the air too, depending upon where you're at. I'm not going to visit very much about the coarse particles, except for to say in general, while there are some health effects, in general the health effects don't seem to be as large or as severe as what we find from fine particles. So how small are the fine particles that we're dealing with? Well, many of you may be familiar with a slide like this already. The width of a human hair is about 60 micrometers in diameter. So if you look at the end of a human hair, a PM10 particle, or a particle that's about 10 micrometers, is the size of this big one that you see. And the tiniest particle there is about 2.5 micrometers. These are extremely tiny particles. This slide actually shows magnified particles from the ambient air. You can see kind of in the lower right-hand corner the 5 micrometer width. So you can see the biggest particles, those sort of big round fuzzy balls, are actually almost 2.5 micrometers in diameter. Most of the particles in the air are much, much smaller than that. So I've added this. The slides that I sent out actually doesn't have these two slides, but this is actually particles that are coal smoke particles. And look again, you can see the 2 micrometer scale there at the very bottom. These are extremely tiny particles. This comes from a recently conducted human controlled exposure study that we've done. And so we looked at coal exposure, and we also looked at aged wood smoke particles. So these again, this is a electron microscopic photo of these very, very tiny particles that come from wood smoke. And in fact, one of the surprises we got from this study was it was difficult actually from the photos to be certain which were the wood smoke particles and which were the coal particles. Of course, these very, very tiny particles are not observable with the human eye, but when you get high concentrations of the particles, as you see here, this happens to be above Salt Lake City during an inversion, you get this brown, sort of ugly looking air due to the high concentrations of the fine particles. Now, this presentation that I'm going to give here in the next few moments is actually not organized chronologically. Sometimes it's sort of interesting to look at the science of air pollution as sort of how it unfolded over the years. But I can do it a bit more quickly if I look at the science methodologically. So what I want to do first is look at studies of short-term exposure. These are studies that look at changes in exposure over a period of hours or mostly days. The so-called episode studies, the population-based time series studies, panel-based acute exposure studies, and case crossover studies. And then I'm going to also look at studies of long-term exposure. So now we're talking about exposures over years or decades. And you can see there's these various study types that I'm going to walk through very quickly. And then there's intervention, natural experiment studies. There's controlled experimental human and animal studies, many of them. I won't be able to get to hardly any of those in this presentation. But what I want to do is as I go through this, I want to stop and at least address some questions. And so there will be some Q&A as we go through this. I know we've got about 300 or 400 people on this webinar, and there's no way I'll be able to get to all of the questions, but we'll try to get to some of them. So first, let's talk about the episode studies, studies of short-term exposure. And I'm just going to very briefly mention them. Most of you are aware of Meuse Valley, Belgium in the 1930s, or Donora, Pennsylvania in 1948, and the very famous London fog episode of 1952. These episodes that occurred over a period of several days resulted in substantial increases in respiratory and cardiovascular disease and death. They demonstrated that air pollution at extreme levels clearly can contribute to respiratory and cardiovascular disease and even death. And the classic London fog episode, many of you have seen this figure. There's no fancy statistical modeling or sophisticated tools being used here. Air pollution went up over a few days in a fairly dramatic fashion, and deaths for primarily, again, respiratory and cardiovascular disease went up very dramatically over that time frame. And in fact, there was a lag structure. The deaths did not really go back down to baseline for about 2 weeks. Now, this actually leads us to when I got started in the air pollution area, really in the 1980s. I moved to Utah from Texas, and there was a steel mill. You can see the photo of Utah Valley there. There's the freshwater lake called Utah Lake, and then you can see there was a steel mill sitting right where the arrow points there. About 250,000, 300,000 people live in that valley, and during inversions, that valley basically served as a natural, human exposure chamber. The local steel mill, Geneva Steel, contributed approximately 50%, maybe as much as 60% of the PM2.5, and it actually shut down for a time period between July 1986 and 1987, resulting in a very fascinating natural experiment. So you can see a photo of Utah Valley on a clean day. On the right here, you can see a photo of Utah Valley on a dirty day. This was before we were monitoring PM2.5. The PM10, which the large majority of it was PM2.5, was about 220 micrograms per cubic meter. And what we did is, we had this 13 months when the steel mill was shut down, and so we just did one study where we looked retrospectively at pediatric respiratory hospital admissions when the mill was operating, then when it shut down, and then after it reopened. And you can see a dramatic drop in bronchitis and asthma, pneumonia and pleurisy, and total respiratory hospital admissions for children when the steel mill shut down. Also was a substantial drop in air pollution levels. And then when the mill reopened, there was this dramatic increase in pediatric respiratory hospital admissions. So this led us to doing not just these studies, but some studies in Philadelphia and Steubenville and elsewhere. That led us to doing another type of study I'll refer to as population daily time series studies. So just staying in Utah Valley where it's convenient for a moment, there's a monitor right in the middle of the valley, the so-called Linden monitor. And this is monitoring PM 2.5 over time. And you're looking here at the black dots are just 24-hour PM 2.5 concentrations. You can see there's a lot of variability in exposure, at least short-term exposure associated with living in the valley over time. Now we can take these data and we can take the number of deaths per day, and right here on this plot you see number of deaths per day plotted over days. But up in the blue plot, we've just simply sorted that data and looked at average deaths per day across quartiles of air pollution. And it's actually, again, there's nothing particularly fancy going on here, no statistical modeling much. We're just simply taking the average deaths per day over quartiles in the upper right-hand corner, and you can see that there appears to be an association. Of course, we're not controlling for seasonality or weather variables. But it's very interesting. Even if you look in the white, in the larger plot, you can see these simple non-parametric smooths, the lines, the kind of lines going up and down showing seasonality. And the two hatches, the two sort of hash marks, it's roughly in the middle of that plot, indicate when the steel mill shut down and then reopened. And there's clearly less within season variability, again suggesting some short-term effects of air pollution. Now in this slide just simply talks about a regression technique, Poisson regression, that allows us to look at these daily mortality counts and model them with respect to pollution exposure over the concurrent or previous couple of days, and then control for seasonality and temperature. Now when we do that, in Utah Valley and elsewhere, what we see is that there's about a 1 to 2% increase in mortality for every 10 micrograms per cubic meter of PM 2.5. And these types of studies, we did them originally, and like I say, in Philadelphia and Steubenville and here in Utah Valley. But these studies now have been done in over 200 cities throughout the world. And if you look at various estimates from meta-analyses of these studies, or estimates now from a number of studies that use many cities in the U.S. and in Europe, and even now some recent studies from Asia, what we see is a fairly consistent body of evidence that if there's increased exposure over a period of a day or two to PM 2.5, we'll see an increase in daily deaths. And again, most of this is coming from respiratory and cardiovascular disease. Now I want to talk about another set of studies, what I'll call panel-based acute exposure studies. To kind of give a feel of what these studies are like, you might enroll a panel of children. And these are actually, this is based on some studies we did in the early 1990s, again here in Utah Valley, but these have been done elsewhere. So you take these children, you keep daily diaries of their respiratory symptoms, also have them do these peak expiratory flow maneuvers or some other measure of pulmonary function. And then you look to see how those change over time with regards to air pollution. So in this slide, the very dark line is PM 2.5, 24-hour PM 2.5 over a winter period. The sort of dotted line is the percent of the children coughing, and that slash line that's going up and down is deviations in peak expiratory flow. Basically what we found is that when PM 2.5 or PM 10 went up, we saw increases in respiratory symptoms, especially cough, and we saw small, transient, but measurable and statistically significant declines in various measures of lung function. So If you look across, say, the studies that we have done with regards to daily time series and these panel-based studies, we can see that there's evidence that increases in fine particulate air pollution are associated with increases in hospital admissions, increases in respiratory symptoms, reduced lung function, although I haven't talked about it in any detail, but the increases in school absences, and even increased respiratory and cardiovascular deaths. Now, more recently, there's been another study design, sometimes often referred to as the case crossover design. I want to just give a brief feel of how that works. So, for example, a few years ago, we did a study of acute ischemic coronary events, so basically heart attacks and unstable angina, in about 13,000 well-defined and followed-up cardiac patients who lived on Utah's Wasatch Front. Now, these data don't allow us really to do time series analyses, but what was fascinating is we have this 13,000 patients. We have very good detailed information about them, and we even have angiography on them, so we actually know how many of their coronary arteries are diseased or have occlusions in them. Now, the way this study is designed is we don't have any controls. All we have is the subjects themselves as they have these events. But if you look at the binary data case crossover figure there, you can see what we do know is we know when the event occurred, and then we know if it didn't occur, say on the same day of the week, 7 days before, 14 days before, or 14 days after. We can actually use the subject's own medical history, if you will, to serve as their own control. So we end up having this sort of case crossover. It's a deviant of the case control design. And we can use conditional logistic regressions, basically, to analyze these data. And so, for example, in this analysis, what we found is that 2-day, 3-day, or even 4-day lagged moving averages of PM2.5 were associated with about a 5% increase in the risk of having these ischemic heart disease events, again, primarily heart attacks. And what was also fascinating about this particular study is that we could stratify it by individuals that had diseased or occluded coronary arteries versus those that didn't. And it was very clear that this increased risk of associated with short-term exposure to PM2.5 only occurred in those individuals that already had occluded coronary arteries, just as you would expect. So this kind of is a very brief, because there's been many of these types of studies done, but this is a very brief outline of the sort of health effects that we've observed from looking at changes in short-term exposure. Now, what I'm going to do now is stop and take a few questions before we move on and look at studies of long-term exposure.
Okay, Dr. Pope, here is one that asks about, in rank order, if you can, what are the worst to inert fine particle species? Is that something you're familiar with?
Yes. The reality is we don't know very well on this, but if I were to try to do the rank ordering, it's clear that the least toxic seems to be sort of just basic dirt, crustal-derived particles, even if they're quite small. So, for example, if you're exposed to very, very high concentrations of coal dust, I'm not talking coal combustion, but coal dust, or even silica, it takes extremely large concentrations over long periods of time to get black lung disease or silicosis or whatever. But if you take combustion particles from burning coal, burning wood, burning diesel, those combustion particles at even relatively low concentrations can result in these substantial health effects. And this, of course, is true with cigarette smoke, it's true with wood smoke, and it's true with smoke associated with fossil fuels. Now, if you look at the combustion-related particles and try to develop some sort of an index of toxicity across them, the literature is not particularly consistent.
All right, we got a couple different questions on, I guess, related to this. Really, there states there are a lot of data that shows sub-daily, say less than or 12-hour wood smoke PM concentrations and 1-hour means that are often exceed 50 micrograms per cubic meter in the evenings or in the morning in wood smoke valley towns. Are there sub-daily wood smoke exposure? Are those exposure a health concern?
The answer is, I think, yes. There is evidence that combustion-related fine particles, even when you're exposed to them over a period of minutes or just hours, you can see almost immediate declines in cardiac autonomic function. You start to see transient changes in lung function. Now, these do seem to be transient. People seem to recover from them. So in terms of the long-term health effects, it's a little bit hard to know. But very, very short-term exposures to, of hours or maybe even minutes can contribute to disease, especially in highly susceptible individuals.
Okay, how about gram for gram? How does wood smoke PM rank with mobile source PM in terms of health effects?
I don't know.
Okay. Here's one that's asked that both the American Lung Association and Australian Lung Foundation recommend against using wood heating when alternatives other alternatives are available, not only because of PM pollution it creates in residential areas, but also from the toxic chemicals, for instance, PAHs. What's your opinion?
Well, I don't think there's any question that when we burn stuff, so whether it be coal or diesel or wood, or tobacco for that matter, if we burn stuff and we burn it in such a way that we have a lot of emissions and we breathe it, we end up having these health effects. And so it makes sense for us to try to reduce our exposure to these combustion-related particles, and that's just as true for wood smoke as it is for say, diesel or other vehicle-related exposures.
All right. Here's one that, is there research that essentially gives us insight on what particle size below the PM 2.5 where there is no adverse health effects?
No, not really. If you look at the exposure response function across concentrations, it appears to be very near linear, at least at the low levels of exposure. And then if you look across different size fractions, it seems like the very small particles seem to matter. I mean, most of the particles we're looking at, or at least most of the mass that we're looking at is less than 2, most of it really even less than 1 micrometer. But even if you get down into the ultrafine particles, there's increasing evidence that they have substantial health effects. And I would say it appears that these very, very fine particles that we can breathe deeply into our lungs, especially those from combustion sources, and essentially all of them are at this size range, have health effects that we should be concerned about. Now I'm going to cut off questions, and maybe you can answer some of them so we can get to some of these long-term exposure studies.
Sounds good.
All right. Well, it's very clear from the literature. I mean, just literally hundreds and hundreds of studies that have looked at short-term exposure. Long-term exposure, there's fewer studies, but yet the results are very fascinating. So what I want to do is now go and look at studies of long-term exposure. So we're looking at studies that look at years or decades of exposure. And we'll start with population-based cross-sectional studies. These are some of the easiest studies. In fact, Lester Lave and Seskin, clear back in 1970 in the journal Science, demonstrated to us that people that lived in cities with higher concentrations of fine particles tended to have, or at least those cities tended to have higher adjusted mortality rates. And that was even true after adjusting for a number of population-based factors that would contribute to these differences in mortality rates. Now, most of those early population-based cross-sectional studies were discounted largely because they could not control for very important factors such as cigarette smoking and other things. So this leads us to the cohort-based mortality studies. And the first of these studies is often referred to as the Harvard Six Cities study. Basically what this study was a 14 to 16-year prospective follow-up of just over 8,000 adults living in 6 U.S. cities. It was a well-designed, elegant study. They monitored various measures of particle pollution, including sulfates and aerosol acidity and various gases. We analyzed the data using survival analyses, including Cox proportional hazard models. Now this approach now allows us to control for individual differences in age, sex, cigarette smoking, body mass index, education, occupational exposures, and various other factors. So here's a figure that just sort of gives a brief overview of the study design. If you look at the horizontal axes, the years of follow-up, this just basically indicates when a time period not individuals were enrolled in the study, and then they were followed up over a period of many years, 16 years at this follow-up, and then a longer follow-up that even included more years. On the vertical axes, you can see the probability of survival. So at time period not, at time of enrollment, everybody was alive. That was a condition of enrollment. And then as you follow them up, you can see that the more polluted cities, Steubenville and St. Louis, the survival was less. There's this sort of splaying out with the clean cities, people dying less rapidly than in the more polluted cities. Now, we can then model these data in much more sophisticated ways using, in this case, Cox proportional hazard survival model, and then come up with these adjusted risk ratios. So now we're adjusting for age, sex, race, body mass index, smoking history, and a number of other factors. And we're looking at the increased risk of living in more polluted areas versus cleaner areas. And the first thing you can see is that, man, cigarette smoking is the biggest risk factor of those that we look at. But air pollution, if you look at sort of smokers versus non-smokers, you get for all-cause mortality roughly a doubling of the mortality risk. But even looking at just air pollution, if you look at those living in the most polluted city versus the cleaner city, about a 26% increase in mortality risk, and that was especially high for cardiopulmonary mortality and quite robust. This led us to do a number of other studies. Well, here's a slide that basically plots that relationship of adjusted increased risk of mortality over the different pollution levels in the 6 cities, and you can see they rise monotonically, in fact, almost linearly. So this led us to do a number of other studies, including collaborating with the American Cancer Society and using their cohort data of over 1 million people and matching that with air pollution data. And basically what we found, using similar sort of methodology, same sort of statistical tools, and basically what we found is similar results as with the Harvard Six Cities study. Increase in exposure to fine particles and or sulfates were associated with increased risk of all-cause mortality and especially cardiopulmonary mortality, so cardiovascular and pulmonary disease. And we saw some evidence of an increase in lung cancer as well. Now these original studies, the Harvard Six Cities and ACS studies, were very controversial, were criticized in various ways, but eventually under the Health Effects Institute, there was this large reanalysis of both of the studies that basically confirmed the results that we originally reported. Following that sort of reanalysis, we had a much longer follow-up of the American Cancer Society study, so we actually reanalyzed those data with the much longer follow-up. This was a paper published in 2002 in JAMA. And again, using increasingly sophisticated modeling techniques, we continued to get essentially the same results. And you can see here that increases in exposure to fine particulate air pollution were associated with increases in all-cause mortality, especially driven by cardiopulmonary mortality and lung cancer mortality. And what was even more stunning, or at least surprising to us back then, was that as we'd analyzed these data more carefully, we found that most of the increase in all-cause mortality was actually driven by ischemic heart disease and related cardiovascular disease. Now, I should note that there have been a number of other cohort-based, prospective cohort sort of mortality studies done looking at air pollution, and I'll just mention a few of those. A fascinating study using the Women's Health Initiative data that was published in the New England Journal of Medicine a few years ago. They were focused on cardiovascular disease, but again, women living in areas with higher exposures to PM 2.5 had more cardiovascular disease risk. There's the Nurses' Health Study again out of Harvard, but a whole different group of individuals than the Harvard Six Cities study. These were all women. Again, there was a strong association with cardiovascular disease and air pollution. There have been a number of studies in Europe, in the Netherlands, Germany, Norway, reviewed recently by Bert Brunekreef, that find similar increases in risk of increased risk of both the all-cause and sort of cardiopulmonary and cardiovascular disease associated with exposure to PM 2.5. Then there's this fascinating couple of studies done by a group at Johns Hopkins where they've used U.S. Medicare data and basically used U.S. Medicare data to construct cohorts and then analyze these data in a very similar way as to what we did in the Harvard Six Cities and ACS study. Again, they see on average across the United States fairly significant increases in risk. So I probably don't want to, it's hard to want to skip over these cohort-based mortality studies because I think they're some of the most important evidence with regards to long-term or chronic exposure to air pollution. But there's also some other interesting studies. So, for example, the cohort and panel-based mortality studies, one of the best ones to maybe look at is this study of California children. So this is often referred to as the Southern California Children's Health Study. They published numerous papers with using these data. But what they were focused on is looking at the effects of air pollution on children's health, especially lung function growth. And what they found is that children living in cities with higher air pollution and those living in cities with higher air pollution showed greater deficits in lung function growth. In other words, their lung function didn't grow as rapidly as those children living in the cleaner cities. And then when they sliced the data in a different way, focused on those children that lived near major traffic sources, so now the exposure is really primarily traffic-related. Again, those with more traffic-related exposure to fine particulate air pollution had greater deficits in their lung function growth. Okay, it's pretty clear, based on a whole host of studies designed to look at long-term exposure, that it's not just day-to-day changes in exposure that impacts our health, but that it's long-term chronic exposure. And what's really remarkable about these studies is they're fairly consistent, but the effects of long-term exposure are substantially larger than those from short-term exposure. As you might expect, that the short-term exposure may result in just transient effects that may be don't extend on into a lifetime, but these long-term exposures clearly do and have very, very important public health impacts. Are there any questions? Yes.
Okay. What is the current understanding of the relationship between acute and chronic PM health effects? You may have talked about this a little bit already. Are chronic health effects simply the acute effects have aggregated over many years?
Well, it's hard to answer that exactly because we don't know for sure. But we do know that the chronic effects do appear to be at least sort of the cumulated acute effects. But many of the more recent studies seem to suggest that it's more than that. So for example, acute exposure seems to exacerbate existing disease, and that's very important. But it appears, especially for cardiovascular disease and lung cancer, it appears that long-term chronic exposure not only exacerbates existing disease, but actually contributes to the development of that disease. Again, talking the development of cardiovascular disease, the development of respiratory disease, and even the development of lung cancer.
Okay. Here's one. Could you discuss the current research associating ultrafine particle exposures with changes to DNA? Any links to wood smoke?
You know, it's a good question. I don't think that I could give it a good answer. The ultrafine literature is quite tricky, and one of the things you learn from the ultrafine literature is that the exposure to ultrafines is actually not as correlated with exposure to, say, PM2.5, fine particle exposures more generally. And so most of the results that I've shown you here are not necessarily evidence of substantial ultrafine particle risk. But now if you look at the traffic and nearness to roads literature, that literature does seem to suggest that ultrafine particles may, in fact, be a bit more toxic and have a bit more, of health impacts than just PM2.5 more generally. Now, I forgot there was a second part of the question. I forgot what it was.
Any links to wood smoke? Yeah.
Yeah. Well, with regards to wood smoke, I think that one of the things about wood smoke, and in many cases, you're actually exposed to very fresh wood smoke. And I've actually tried to study both fresh wood smoke as well as aged wood smoke. And in all honesty, right now, the results are not consistent enough that I'd try to make a strong inference.
Okay. What classifies as long-term exposure? What about populations with poor air quality all winter, but excellent air quality in the summer months, assuming that there are no wildfires?
Yeah, that's a really good question. And the way these studies are designed, we're thinking long-term exposures, basically just average exposures throughout the entire year, but these average exposures over a period of multiple years or even as long as decades. Now that's the definition basically for the study designs themselves. If you tried to say stratify these analyses based on cities where the exposure is more consistent across the year versus, say, like where I live, where the exposure is quite high in the winters, and even then only during episodes, but quite clean in the summer. When you actually stratify the analyses that way, it doesn't seem to matter very much. It seems like the average exposure seems to matter the most. And I think I'll probably leave it at that. So most of us that are doing these studies think that average exposure, reducing your average exposure is probably the highest priority, and reducing short-term exposure is probably important, but not as high a priority for long-term health of an individual or the public health in general, it's not as important as reducing sort of long-term average exposures.
Okay, how about we do one more? With the federal PM 2.5 standard as a 24-hour standard, it is difficult sometimes to communicate about the risks of extremely high short-term levels, especially in terms of AQI, etc. What are your thoughts about need for a 1-hour standard or for guidelines on communicating the risks from short-term exposure?
Well, you know, that's really tricky. But as I indicated before, the risks to very short-term exposure still are mostly with those that are highly susceptible. So, for example, I showed that case crossover study that showed that for ischemic heart disease events, there was really no increased risk in individuals that had clean coronary arteries or they had healthy coronary arteries. Essentially, all of the excess risk was in individuals that already had existing coronary artery disease. And this seems to be true in our panel studies for respiratory disease. While we see changes in respiratory function for all of the children, including the very healthy children, it's the asthmatic children and those that already have significant deficits in lung function that are most susceptible to these very, very short-term elevations in exposure. So when you communicate this, I think for the short term, it's very important for people to understand that those most at risk are those with existing disease. Now, on the other hand, if we're talking about long-term exposures, the evidence seems to suggest, for example, that California Children's Health Study seems to suggest that average exposures, even moderately high exposures over long periods of time, actually reduce growth in lung function and actually contribute, based on other studies, contribute to the development of this of disease, which then will make you more susceptible to these short-term episodes of spikes in pollution. So let's just move ahead briefly to these intervention and natural experiment studies. Now these are very well motivated. The early studies, it was an intervention natural experiment study, the Utah Valley study with the closure of the steel mill. That's sort of a classic natural experiment study. But what I want to do is go to sort of a naturally motivated study that was published a couple of years ago in the New England Journal of Medicine. So this is a study I did with Majid Azadi and Doug Dockery. And basically what we were doing is using about a 2-decade period in the United States where there were substantial differential reductions in air pollution, largely due to our efforts to reduce air pollution and other factors. And so what we had some cities that really cleaned up a lot more than other cities. And we wanted to use this evidence as basically we're going to treat this as a great big national natural experiment where some cities cleaned up a lot more than others. We have matching data for 1979 through 1983 and then 1999 to 2000, so spanning approximately a 20-year period. We have these data matching for 51 metro areas in the United States. Obviously, I wish we had it for every metro area, but we only have it for 51 metro areas. And then we can create life expectancy data for that same span in all of the 211 counties that exist in those 51 metropolitan areas. And then we're going to evaluate changes in life expectancy with changes in PM 2.5 for this 2-decade period of approximately 1980 through 2000. Now you understand these prospective cohort studies that demonstrate the increased risk of life expectancy, the increased risk of cardiovascular and lung cancer mortality, they would predict that there would be a measurable and significant difference in life expectancy across communities that had substantial differences in their changes in air pollution. So what we've done is we've created these data sets with this matching data, and we not only have air pollution data, but we have various socioeconomic and demographic variables that we can use in our analyses. You can see them listed here. We also could create proxy cigarette smoking variables for all of the counties, basically COPD, or chronic obstructive pulmonary disease mortality rates and lung cancer mortality rates. Or we had, at least for about half of our metro areas, we had survey-based metro area estimates of smoking prevalence. Now we can take that data and do clustered regressions for the data that we have. And the bottom line is that when you do this analysis, the results suggest that for every 10 microgram per cubic meter decrease in PM 2.5, there was an associated roughly 7-month increase in life expectancy. The increase in life expectancy persisted after controlling for the socioeconomic and demographic smoking variables, and if you sort of do the math, these are almost exactly what you'd expect based on the differences in risk that we got from the prospective cohort studies. And to sort of visualize this, in this upper panel, this upper scatter plot, this is the change in life expectancy across those 20 years associated with reductions in PM 2.5. Now you can see there's a lot of scatter indicating that change in life expectancy was associated with lots of other things that wasn't necessarily air pollution. But in the lower panel, what you're looking at here is the residual changes in life expectancy after controlling for the socioeconomic covariates that we had. And it's actually really quite amazing what a robust and consistent increase in life expectancy there was after controlling for the other things associated with reductions in air pollution. This is, of course, consistent with the interpretation that our efforts to reduce our air pollution or exposure to PM 2.5 have had substantial public health benefits. And then I probably ought to just very briefly talk about the idea that there's now a great deal of literature, experimental human and animal literature or research, that adds evidence to the biological plausibility of these epidemiologic findings. And I'm not going to go through very many details here, but just for example, there's been a parallel research with regards to cardiovascular disease regarding chronic and acute inflammatory processes. And we've come to learn that inflammation really contributes to acute thrombotic complications of atherosclerosis, and even increases the risk of the initiation and progression of atherosclerosis. And some of this work has been done, again, not related to the air pollution literature, but basically looking at various markers of cholesterol. So in this figure, you can see on the one axis, there's this quintile of total cholesterol. On the other axis, there's this quintile of high-sensitive C-reactive protein, which is a marker of inflammation. And you can see that while the more inflammation you have, there's a higher risk of cardiovascular disease. The higher cholesterol you have, the higher risk you have. But if you have a combination of high inflammation and high cholesterol, you get a dramatic increase. In fact, you can see around a 9-fold increase in risk of cardiovascular disease. I mean, 9-fold. This is just, this is getting up there, and even greater than smokers versus non-smokers. It's really huge. Now, of course, smoking contributes to inflammation, and part of the reason that smoking increases our risk of cardiovascular disease clearly has to do with its impact on pulmonary and systemic inflammation. So so you ask, well, what does this have to do with air pollution? Well, we know that fine particulate exposure to air pollution, or exposure to fine particulate air pollution, contributes to pulmonary and systemic inflammation and oxidative stress. That, in combination with blood lipids or cholesterol, we'll see this increased progression and then the destabilization of atherosclerotic plaques. And so, for example, if we go back and look at some researchers at the EPA went and took samples that had been archived of the air, so these filters that had been archived back when Geneva Steel was operating and versus not operating in Utah County. And then they used the particles from those filters and they instilled them in human lungs and in rats and did a series of these studies, and it became very clear that exposure to these particles resulted in acute airway injury and inflammation. It also became clear that they would induce oxidative stress, and there was this release of pro-inflammatory mediators in these cultured respiratory epithelial cells. The other interesting thing was the analyses that they did there did demonstrate that there seemed to be differential toxicities of PM, that it seemed to be more toxic when the mill was operating versus when it was not, suggesting that metals or other mixtures associated with steel mills were particularly toxic. There have been a series of studies by Van Eden, Hogg, and others that have suggested that PM exposure is associated with pulmonary inflammation. I won't go through this in details, but then they went to, they had these rabbit models. So these were models of rabbits that were highly prone to develop atherosclerosis, and found again that PM exposure accelerated the progression of these atherosclerotic plaques and resulted in greater vulnerability to plaque rupture. Another interesting analysis, this is a study done by Sun et al. At NYU. Again, they were using these hyperlipidemic mice, exposing them to air pollution over this was basically chronic exposure over a period of months. They had two groups of mice, some that were fed a normal chow diet, others were fed a high-fat chow diet, and then each of those groups were divided up into half. Half were given clean filtered air. Others were given polluted air. Incidentally, the air wasn't any more polluted than what we often get in our inversions here along the Wasatch Front in Utah, and is common in some of our wood smoke communities in the United States. So these are environmentally relevant levels of air pollution. And you can see just based on these samples that the atherosclerotic disease, that basically the occlusions of these arteries were higher for the high-fat chow versus the normal chow, but for both of them, those that were exposed to air pollution had more rapid progression of atherosclerotic disease than those that were exposed to just clean air. So just to summarize, there are now many studies using many study designs and approaches with companion statistical modeling approaches and techniques that have provided a remarkably coherent evidence base indicating that exposure to fine particulate air pollution contributes to cardiovascular and respiratory disease. Just last year, myself and Robert Brook and a large group of researchers put together the American Heart Association scientific statement with regards to the evidence of cardiovascular effects of PM 2.5. And again, while all of the pieces of the puzzle don't exist yet, it's remarkable how coherent and consistent the evidence has become. I'll open it to questions again. Okay, I'll tell you what, before we open it up, let me make one more comment that's related to wood smoke, or at least somewhat related to wood smoke, and then we'll come back and I'll take questions as long as we need to. So what I'm going to do next is just address one issue that tended to come up a lot And that has to do with the argument that, wow, well, there were basically two criticisms of this literature. One criticism was that the increased risk that we're seeing from air pollution, and incidentally, we're getting the same argument for secondhand cigarette smoke. So both secondhand cigarette smoke and air pollution get us risks. You know, if you live in a high polluted city, or if you live with a spouse that smokes, your risk of cardiovascular disease are roughly 25–30% higher than if you're not exposed. Now, what's amazing about that is some would argue, 25–30%, that's not very high, and epidemiology can't really address that issue. Now, that's not true, by the way, and so I'm going to ignore that argument mostly. But there's another argument that's much more valid and of concern, and that is to say, if you actually look at the estimated dose of the daily dose of exposure to PM2.5 or fine particles from smoking cigarettes, say 18 to 22 cigarettes per day, you can see on this slide that the increased risk is at least double. But then if you do a linear extrapolation back to no excess risk to no exposure, you'll see that star and that triangle there, or diamond, I guess it is, that star and diamond, you'll see that those excess risks are substantially higher than what would be projected by a linear extrapolation from the active cigarette smoking literature. And why that's important is because we have to remember that secondhand smoke and air pollution, and this would be true with, now remember that the secondhand smoke is not burning wood, but is burning tobacco, which is now you know, very different than many of our exposures in urban environments. But we're getting almost the same sort of increased risk relative to the same sort of exposures. But yet they're much larger. The effect estimates are much larger than we'd get from a linear extrapolation. And so then the question is, well, does it make sense to have a linear extrapolation from the smoking literature? And so we said, let's go back to the American Cancer Society cohort and actually look and see if it does make sense. So on this slide, what you see is the increased risk, or the adjusted relative risk, associated with smoking different increments of cigarette smoke, less than 3 cigarettes per day, 4 to 7, 8 to 12, etc. And then what's fascinating is if you were to draw a line through them, assume linearity, and draw a line through them, what you see is a straight line fits pretty good, but it doesn't go through the origin. It goes right through the vertical axes at about 1.6 relative risk, about 60% excess risk. And so what this tells us is that there must be something wrong with our analyses, or there must be something really magical about that first puff of cigarette smoke that, bam, jumps you up 60% excess risk. Or it tells you that the exposure-response relationship is not linear, but it's curvilinear. It goes up very steeply through low levels. There's this sort of saturation phenomena that's occurring where you get this rapid rise in risk associated with increased exposures, and then a leveling off at the very high levels of exposure. That's consistent with the smoking literature as we estimate it from the American Cancer Society data. And so then you might ask, maybe we just have this scaled wrong. Let's just simply scale the horizontal axes. Instead of being linear, let's scale it as log linear, which leads us to this next slide, suggesting that the increased risk is essentially linear over the log scale. Now, I'm not going to go beyond this, but I'll say we've just recently finished an analysis, similar analyses looking at lung cancer. And with lung cancer, the risks continue to go up nearly linearly. But for cardiovascular disease, the empirical evidence is pretty clear that there's a saturation phenomena going on, and the risk is very steep at the low levels of exposure and then levels off. And I'm quite certain that would be true for wood smoke as well. Now, questions.
All right, we got several. What long-term, short-term studies are there specifically about exposure to indoor air pollution? And of course, there is information out there that shows wood smoke in homes, particularly improperly installed and operated stoves, can pollute indoor air. Do you have any experience and knowledge on this, Dr. Pope?
Well, I do, and that's very important, and that's one of the reasons I wanted to show this nonlinear exposure-response relationship, because many of the studies on indoor exposure, especially to wood smoke, come from studies where individuals are using wood for either heating or cooking, and sometimes in unvented stoves in their homes. So the exposures are extremely high, and what you get is associations that are roughly comparable to what we would project based on this nonlinear exposure-response relationship that I just showed you. And then again, if you want to focus on indoor exposures, it's not so true in the United States, because in the United States, most of our indoor exposure just is secondhand cigarette smoke. And incidentally, the secondhand cigarette smoking literature seems to almost parallel what we see with the ambient air pollution literature. Roughly the same increases in concentrations in terms of the exposures result in roughly the same increases in risks. But if you go outside of the United States to areas where there's indoor cooking and indoor heating with poorly vented stoves, you get dramatic exposures, and you start to see very substantial increases in risk of both respiratory and cardiovascular disease. And it seems to be true whether it's wood smoke or coal smoke or whatever. Another common source are these dung cakes, or burning manure or dung in stoves as well. Again, you see these same sort of effects.
Okay, I'll add that for those interested in the indoor air issue, Dr. Tony Ward and Curtis Noonan from University of Montana have done some research on wood smoke, wood combustion in homes, and so have some good findings. And you could just Google wood smoke, particularly Libby, Montana. There's some good indoor studies there on here in the United States that could be relevant to a lot of folks. Let's see, here's another question. We have sometimes received complaints about the odor of smoke when our air quality monitors are not picking up much. Let's see, how strong of evidence is there? I kind of lost my track here because the screen moved. Anyway, it's essentially, what can we tell us about the smell of smoke versus monitoring? And if you're not picking up on a monitor, is there do you know anything about that?
No, I couldn't answer that.
Okay. Here's one. It goes back to some of your earlier comments on your studies. Would the patients that died during an episode have died anyway, just days or weeks later?
Yeah, that's an excellent question. And we've studied that actually very carefully. I've done some myself, and the group at Johns Hopkins, as part of the INMAPS studies, Joel Schwartz at Harvard spent a lot of time looking at this, and the answer seems to be no. I mean, it used to be this argument that that basically there's just a harvesting of the most susceptible, or the more politically correct term, I think, is mortality displacement. If you actually look carefully at that issue, what you see is that it looks like these people would not have died within a few days or even within a few weeks. Now, of course, they eventually would have died, but it seems like that these time series studies are not just picking up a so-called harvesting effect.
Okay. Let's see, here's one. In terms of metal composition of PM 2.5, what is the typical composition in urban areas? Does it differ between East and West Coast? Let's see, how strong of evidence is there linking this component of PM 2.5 to the adverse health effects? So is there a difference in metal composition in East Coast, West Coast, urban?
Yeah. Well, there is. Now, it's less an issue of East versus West, although there clearly is a difference between East versus West on average. But obviously it differs largely based on what your primary sources are. So if you're living somewhere where you have an integrated steel mill, living somewhere where you have a copper smelter, especially poorly controlled copper smelter, there are sources where the metal content and it will be very different. Or I'm sorry, there are areas where the metal content will be very different than other areas. And again, it's hard to generalize East versus West, because there was a time out here in the West where there were a number of sort of poorly controlled copper smelters, of course the steel mill that I already talked about, that made it look, made the profile of air pollution look almost more industrial than sort of Western cities. But that being said, there are differences in metal content. And if you look across the world, there's some really dramatic differences. And there is increasing evidence that some transition metals do matter a lot in terms of the toxicity of the PM mixture. And this is an area that we really need to get figured out and need to do more research. That all being said, we still continue to see these inflammatory and cardiovascular responses, and even the lung cancer responses to particles that aren't, don't have excessive amounts of metals in them. And so it seems like it's more than just metals, but metals do contribute.
All right. We do have a couple more questions, actually a few more, but we're going to have to, I think we're going to go ahead and just wrap up. And one, really thank Dr. Pope for his time and for everyone's time, for particularly for staying long. We appreciate everyone's time and energy and focus on this. We're going to post essentially the slides today on our BurnWise website, and then in a couple days we'll have the recorded version of the webinar up on our website also. We have a survey that we would like folks to take a look at. We're trying to find out a little bit more, is this kind of webinar useful? What would you like to see more of? You'll see there's a whole series of, a handful of questions we'd really love your feedback on to help improve our programs and provide information that's useful to our states, locals, and tribes, others that are addressing and looking at wood smoke. So I want to again thank Dr. Pope for a wonderful presentation and for the time, and for everyone who's stuck with us here. It's been a very good session, I believe, and you can get to our website and check out the slides and information again. All right, thanks a lot. Thank you, Dr. Pope. All right.
Thank you. Bye.